Welcome everybody to Dementia Research Night 2025. I'm Jeanette Sears and my coworker Christy Bannerman is here with me. We are the public education coordinators at the Alzheimer Society Huron Perth. So welcome back for another year. First, I should thank our sponsor for this program, the Municipality of Central Huron. They have been supporting this event for many years, so we really appreciate their support. And then I would like to introduce, of course, Dr. Sharon Cohen, and Justine Rome has also come here from the Toronto Memory Program as well. So Dr. Sharon Cohen is a behavioral neurologist, and she's known for her excellence in patient care and teaching and clinical research. She is the medical director of the Toronto Memory Program, which is a community-based medical facility. And Dr. Cohen established this in 1996 for the purpose of enhancing diagnosis, medical care, and therapeutic options for individuals living with or at risk for Alzheimer's disease and other disorders. And her memory clinic, the Toronto Memory Program, and the research site are among the most active in Canada. Dr. Cohen has over 30 years of experience in clinical research and pharmacological trials, and over 200 studies as well, or 200 studies. In addition to her focus on Alzheimer's disease, she's also participated in research trials for acute stroke, frontotemporal dementia, Parkinson's disease, Lewy body disease, Huntington's disease, and vascular dementia. Her research is seen as a go-to center for trials that are related to Alzheimer's disease, and they've been awarded many awards for superior performance and quality in clinical research. Some of you might remember that Dr. Cohen joined us here for Dementia Night in 2022. And I know Christy and I were talking about this earlier. You know, at that time you mentioned some of the details regarding diagnosis and including blood tests. And over the past 3 years, yes, we've seen more of those things get a little closer, right? That research is advancing. Now, again, this fall 2025, Dr. Cohen and the Toronto Memory Program has been in the news often recently, especially regarding their involvement with the new treatment, lecanemab, and its potential impact in Canada. So again, Dr. Cohen, welcome back to Dementia Night 2025. We are so looking forward to hearing what you have to share this evening regarding treatment and research updates.
Thank you so much, Jeanette. Can you hear me well?
Yes, we can.
Yes. Okay, I'm going to share my screen. Let me make sure I can do that. And then we'll be okay. I'll put it on slideshow. Okay, are you seeing that all right? Yes? Okay, good, good. All right, really a pleasure to be with you. Thank you so much for inviting me back. 3 years have gone by, 2022, when I spoke with this group. You were a wonderful audience. You shared the hope and enthusiasm that the future was going to get brighter, and it has. So I'm glad that I spoke the truth, no false hope here, that things have advanced. We still have a ways to go, but let me share with you some of the things that are different than advancements over what we were talking about and hoping for in 2022. So what I'd like to do is to provide an update on what's new in diagnosis, what's new in treatment, and not just treatment that has now come to the market, but what the drug development pipeline looks like. What can we expect over the next years? And I want to provide a call to action for those who are wishing to embrace either the current progress or needs that are still to be addressed. So before I go to what's new in diagnosis, let me just say that some of the things in Alzheimer's disease remain. And you may recognize some of the slides that I show you as ones that I showed you 3 years ago to signify that there are still important needs. We haven't cured this disease. However, there are 4 main buckets of advancement. One is that we have a new treatment just approved in Canada and more to come. And around the world, we have 2 new disease-slowing treatments. The second is that we do have blood tests now to diagnose Alzheimer's, and I'll talk more about that. That's amazing. I was saying in 2022, they're under development, they're coming. Well, they're here. The third thing is the drug development pipeline, which is the hope for future treatments, has continued to expand. When we look at the 2025 pipeline and what's in there compared with just last year, more drugs, more trials, more interesting mechanisms of targeting Alzheimer's. And fourthly, there are over 30 drugs being tested in phase 3. And you might recall from the COVID days that drugs have to go through phase 1, 2, 3 development before they can be deemed to cross the finish line if they're successful and get regulatory approval. And we have 30 odd drugs already in phase 3 in Alzheimer's. And what that means is we are going to start to see approvals over the next years. We're not going to wait another 20 years between now, a new drug, and the next new drug. So that is extremely hopeful. So let me continue on here. So this hasn't changed. 55 million people worldwide. I should say it's gotten worse. The numbers keep climbing. 150 million people will have Alzheimer's disease by 2050. And here you see some of the famous celebrities, actors, politicians who have been known to have Alzheimer's disease. And there are many, many, many more faces that should fill this slide just to help us think about the pandemic we're facing. And we probably don't have to look at celebrities within our own lives. People we love and care about or know of have succumbed to this disease. So this really needs a solution. And this is not just a common disease, but a disease with a huge personal burden. And those of you who love the movies, The Father with Anthony Hopkins, this was not an exaggeration. This disease does take a terrible toll on people and on families. Still Alice, another movie with a very accurate rendition of autosomal dominant Alzheimer's. And so the World Health Organization deemed Alzheimer's an urgent healthcare priority as early as 2012, not just because of the huge numbers and the severe morbidity, but also the enormous costs of care. And you would think with a common disease, we'd be good at diagnosing it. But in fact, we are underdiagnosing and diagnosing late. And less than 50% of people with Alzheimer's. So I told you the numbers of people, that's an underrepresentation because people don't come forward. They don't get diagnoses. They often try for years to approach the healthcare system without a diagnosis. And when the diagnosis is made, it is often inaccurate, especially early in the disease. About 50% of people at the mild cognitive impairment stage of Alzheimer's will not get an accurate diagnosis. Some will be told they have Alzheimer's when in fact they don't if we have more biological testing available. So what are the diagnostic challenges and what's being done about this? Well, one reason for delayed diagnosis is that patients may not recognize their own symptoms and therefore not report them, not because they're in denial in a psychiatric sense, but because the part of the brain that allows you to reflect on how you're doing may not be working in some people with Alzheimer's. And so they don't think anything's wrong, and it's up to the family then to bring them in, or the employer recognizes something. That's challenging. Then for those who do recognize something's changing, there is fear, there is stigma. Don't know if I want to see the doctor. I'll lose my driver's license. I'll be told there's nothing we can do. So that really holds people back another year or two before things get desperate and they see the doctor. And in general, we've had many physicians who don't feel confident diagnosing and managing Alzheimer's, and the interest in Alzheimer's disease has been relegated to a very small proportion of specialists, not nearly enough to manage the Canadian need. Symptoms are often confused with normal aging. And we expect that people will be forgetful as they get older. Well, we should rethink that because they may be developing a serious disease. This might not be normal aging. And our cognitive tests historically have been insensitive for early disease stages. So people may say something's changed with my memory. I do a test and I say, well, nothing to see here, everything's normal. Well, it might be the fault of the test not being sensitive enough, not that the person is inaccurate about a change in their memory or thinking. And the lack of a simple diagnostic test has been a huge barrier. So if we fast forward to now, fear of stigma and loss of independence changes dramatically when you have a new treatment. More individuals come forward. They feel hopeful. There's a new drug. And we've seen this in stroke and cancer, multiple sclerosis, where people are not holding back now. Our phones are ringing off the hook with this Health Canada announcement 2 weeks ago of lecanemab. Physicians also take more interest and they get more education. So all of a sudden, across the country, specialists and individuals in primary care, family docs are being educated about how do you recognize the early stages of Alzheimer's disease? How do you think about what these new drugs can do and ensure that your patients don't miss a treatment opportunity? Education on how to differentiate between normal aging and early symptoms of Alzheimer's is also going on, and new tests are being validated, including virtual tests that are more sensitive than some of the paper and pencil tests we've had to assess cognition. And finally, blood tests have arrived, as I've mentioned a couple of times, and this is a big deal because a blood test to diagnose or confirm the diagnosis of Alzheimer's disease saves patients and our healthcare system from expensive and sometimes invasive tests that we've had previously, PET scans, which I talked about in 2022, and spinal tap. Yes, they have a role still, but if you can do a blood test instead, so be it. So Alzheimer's disease is this long disease, 30 years or so, and the first 1 to 2 decades, people have no symptoms. They have changes in the brain going on, accumulation of a protein called amyloid, and then another protein called tau. These are bad actors in Alzheimer's. They damage the brain, and you have to wipe out a lot of brain cells before you start having symptoms. The brain is a marvelous organ, and it can tolerate a certain amount of abuse. But after you lose the first million neurons, you start to decompensate and have symptoms. And on cognitive testing, I may then be able to see something's not right with memory or thinking. That first symptomatic stage is called mild cognitive impairment, where people have a cognitive complaint, they have impairment on a test, but they are still independent. They are still working, they may still be driving, banking, traveling, engaged in active social life, family life. That's not to say there isn't frustration, not to say that they might need some compensatory strategies, but they're still managing independently. After a few years of the mild cognitive impairment stage, unchecked, we progress to the dementia stage, mild, moderate, and severe dementia, where increasing loss of independence occurs. So initially, maybe I can't drive, but I can do other things, can't look after my finances, but still can do some traveling. In the middle stage, I'm needing help with showering, choosing my clothes. In the late stage, I'm actually completely dependent on others for personal care and for all activities. So this is the nature of this disease. And we've relied previously on people coming forward with symptoms. We've been dismissive of the mild cognitive impairment stage of disease, and we've been diagnosing people late in the dementia stage. And pathologically, on autopsy, there's amyloid plaque and tau, but this is autopsy. We want to diagnose early in the disease in life. The brain shrinks again at autopsy. It shrinks because we lose millions of brain cells. We want to act early because once brain cells are lost, hard to bring them back. But if you can protect them from dying, that's the way to go. So can we make a diagnosis of Alzheimer's in life and early in the disease? Well, absolutely. And we now have 3 modalities to confirm the biologic diagnosis in somebody we suspect has Alzheimer's disease by taking a history, doing some cognitive testing. So amyloid PET scans we've had for a while. Since 2017, we have one amyloid tracer approved in Canada. Spinal fluid measurement of amyloid and tau we've been able to do for a while. Blood tests to determine the presence of brain amyloid. Think about that. That's what we have now. Blood tests that can tell you whether the brain change of Alzheimer's, amyloid accumulation, is going on. And here's someone having a PET scan. And we see on the right the PET image of amyloid. Amyloid is in red there. And this person has a head full of amyloid. But the amyloid becomes abnormal early in the disease. So this person may have no symptoms. They might be in that pre-symptomatic stage. They might be at the mild cognitive impairment stage. They might be at the dementia stage. But what we know from this amyloid PET scan is that they do have the biological confirmation of Alzheimer's disease. Spinal tap, with one precious vial of spinal fluid, we can measure not just amyloid, but tau and other proteins as well, proteins of inflammation and other markers. And although some people think of the spinal tap as invasive and scary, most of our patients tolerate this very well. And we do spinal taps every day in the clinic and on the research side, because we haven't had a blood test in large part. That's the reason. But now, as I've said, blood tests are here. And there are several validated blood tests for Alzheimer's disease. When I say validated, they've been through rigorous studies, and they have what is called CLIA approval. So CLIA is a laboratory standard of approval. They are 90% accurate, and that's comparable to the accuracy of spinal fluid biomarkers. 2 of them already have FDA regulatory approval just this year. One has been approved in Europe, so that's called the CE mark for those of you who are technically inclined, and others are under regulatory review as well. Most are available in Canada, although we don't have Health Canada approval. Health Canada, I'm sorry to say, as a proud Canadian, is very slow. Health Canada, we will have it, but the the biomarkers can be ordered, and we do order them on Canadian patients in our clinic because they are validated. They are CLIA certified. This is important to know. The current indication for appropriate use of these biomarkers, these blood biomarkers, is for those who have cognitive symptoms, are under the investigation for Alzheimer's disease as a potential cause of their symptoms, and the individual is 55 years or older. There is one of these blood tests that's been validated down to 50 years and older, but they are not as accurate or reliable in people with very early onset, 30s, 40 years. Okay. Back in 2022, I did tell you about an eye scan that's under development. It is in the final stages of validation studies at our clinic. It's called the ReadySpec scan, hyperspectral imaging, looking at the back of the eye and detecting the signature of amyloid. And it has high accuracy and is going through final validation processes, and then will be reviewed by regulatory authorities. So we're hopeful that optometrists and ophthalmologists in their annual exam of their patients, eye exam, will also be able to screen for the early changes of Alzheimer's disease. Genetic testing, that has been available again for several years. There are rare gene mutations that can be detected in blood sample, and these rare gene mutations can directly cause Alzheimer's. But there's also a major risk gene called the ApoE4 gene that can be detected in blood and from a cheek swab. And individuals who have causative or risk genes have options for prevention and treatment, both for research studies, but also with approved treatment now. So here is Kathy Barrick, the CEO of Alzheimer Society of Ontario, having a cheek swab. She wanted to do this to demonstrate this was painless, this was easy, and to lead by example. The DNA analyzer is a 4 by 4 inch cube. It was called the Spartan cube. Now it's owned by Genomatics, but smallest DNA analyzer in the world, developed by Spartan Bioscience in Ottawa. And it can detect within 1 hour of processing from a cheek swab whether you have 1 or 2 copies of ApoE4 or what kind of ApoE genotype you have. So it could be a 3-3, a 2-3, a 3-4. And that becomes important when I talk a little bit about the new treatment, lecanemab, that's been approved. So let's move on to new treatments. So up until 2 weeks ago, October 24th, when lecanemab was approved. Up until then, the last approval for an Alzheimer's drug in Canada was 2003. Can you believe that? It was like, 22 years ago. And the previously approved medicines, those approved up until 2003, are 4 specific medicines, 3 in a class called cholinesterase inhibitors, and 1 a glutamate modulator. And you might know these, some of you might know these by the names Aricept and galantamine, rivastigmine, or Reminil is galantamine. The glutamate modulator is memantine. And what these do is they improve how brain cells talk to each other by adjusting levels of neurotransmitters. So they act rather late in the biology of the disease. When brain cells are dropping out, there's not enough acetylcholine. We boost the amount of acetylcholine and we get modest benefit. So when these drugs started to be approved in the late 1990s, early 2000s, this was the first time we had any treatment. And this was to boost cognition, so people get a little bit of benefit to memory or to language abilities. And this was a big deal. But we know that this is a modest benefit, and it does not prevent or slow the underlying disease because it doesn't get at amyloid, it doesn't get at tau or the early brain changes. And importantly, none of these existing treatments were ever approved for the mild cognitive impairment stage of disease. So people had to get worse before they were eligible, which is very frustrating because when you detect an early, a serious disease early, you want to jump in and treat it. And yet we didn't have these approved for the mild cognitive impairment stage. So a new chapter in Alzheimer's treatment, July 2023. So that's 2 years ago, 2.5 years ago, the FDA gave full approval to a drug called lecanemab. The brand name is Leqembi. A year later, July 2024, the FDA gave full approval to a second drug, donanemab, or Kisunla is the brand name. And each of these are antibodies that clear amyloid from the brain. They're given by intravenous infusion, and they are indicated for the early stages of Alzheimer's. So that mild cognitive impairment stage where we've had nothing, and the mild dementia stage. So we don't want to miss a treatment opportunity. And this is bringing people forward. As I said, our phones are ringing off the hook. People don't want to progress and be told that this new drug is not indicated for them. The goal of these drugs is to slow down the disease and slow it down at the early stages where people are still in their own homes and functioning pretty well. And here's the power of these antibodies that target amyloid, as seen on the cover of Nature magazine several years ago. On your left, you see in red amyloid accumulation, very dramatic accumulation because of the disease. And after several treatments with an antibody that clears amyloid, that amyloid is gone. Now, we haven't cured the disease. The amyloid's gone. It's not quite the same as getting all of a tumor and taking it out because the precursors of amyloid plaque continue to be formed. So it's a continuous process, and until we shut off production, we're going to gradually reaccumulate amyloid. Nevertheless, this is a really dramatic rendition on a PET scan of what these drugs can do. And by September of 2025, lecanemab and donanemab had attained approval in 50 countries around the world. And I felt this sick joke coming on as we were waiting for Health Canada. I felt like, okay, we're going to be the 51st country. And I didn't want that to be true, but it is. And in this instance, we'll embrace the approval. So October 24th, Health Canada finally on a Friday night approved lecanemab, and we had to embargo all of our press releases and everything else until the Monday. But this marks the first disease-slowing treatment for Alzheimer's in Canada. Public cost coverage is under review, and the recommendations are expected early in 2026. The drug is being shipped from Europe to Canada, so people will receive first doses probably next month in December. And the Health Canada label requires, as with around the world, biomarker confirmation of Alzheimer's. So it's not enough for me as a skilled clinician who knows this disease to say, I think this person has Alzheimer's. I need to say they have the clinical syndrome of mild cognitive impairment or mild dementia. I think it's due to Alzheimer's, and I need to get a biomarker to show me that there is amyloid accumulation in the brain. So that changes things. We haven't needed that with our existing treatments with the cholinesterase inhibitors. We just go by clinical criteria. We don't need to confirm. But if you think about it, when you treat cancer, it's not enough to say, oh, that lump looks like cancer. We need a biopsy or some way to know the tissue diagnosis so that we can fine tune our treatment. And heaven help us, we don't want to be treating with cancer chemotherapy, something that ends up not being a cancer. So it makes perfect sense. If you're targeting amyloid with a drug, you want to know that amyloid's there and this isn't some other condition. Importantly, the Health Canada label also excludes patients from lecanemab treatment if they have 2 copies of ApoE4. So having 2 copies of ApoE4 is uncommon. In the general population, it's about 2%. In the Alzheimer's population, though, it's about 15%, and a lot of us feel this is wrong. The reason Health Canada is excluding these people is because of the concern that side effects are more prevalent when you have 2 copies of ApoE4. However, we'll see that is not how the FDA or the Japanese PMDA approved the drug. They allow all ApoE genotypes. So we'll see if there's some modification of that over time in Canada. So what does lecanemab do? It robustly clears amyloid. Within 3 months of initiating treatment, we see already a substantial clearance, and that continues. It slows decline in cognition and daily function so that people stay mild longer. And we see that as early as 6 months. So 3 months, amyloid's coming out. By 6 months, we see people staying more stable. This drug reduces the risk of transitioning to the next, more disabling stage of the disease. And it preserves quality of life as assessed by patients themselves. And also, when you ask caregivers who were involved in this study, they reported less burden. And we weren't deciding that for them. That was their determination compared with care partners of those on placebo. And of course, these were blinded studies. People didn't know whether their loved one received active lecanemab or a placebo. And yet the results came out just as we had hoped, that those who are on active drug, better quality of life, less care partner burden.
All right, I'll go downstairs in a second.
When we treat early, now we have data out to 4 years, because the studies, the pivotal studies that led to approval by the FDA in 2023 had a 4-year open label extension. So we have long-term treatment, and we see that at 4 years, people are continuing to improve. They're saving about a year of time, that's substantial, at the early stages. And those who had the lowest burden of amyloid or tau at the start of treatment initiation showed improvement. Some of them even improved. Even though we're giving the drug to slow down the disease, some of them even improved up to 4 years after treatment initiation. So that's not something that we've seen in the past. There can be side effects with any drug, and it's worth knowing about these. There is a first type of side effect called infusion-related reactions, and that occurs in about 1/4 of people. But fortunately, it's mostly mild or moderate in severity, and it usually doesn't need pre-medication. Usually occurs only with the first intravenous dose. And what is an infusion-related reaction? Chills, headache, malaise, just not feeling right, or well flushed, and that can occur during the infusion or within the first 24 hours of an infusion. But it's not a deal breaker. Very few people would go off the drug because of infusion-related reactions. The more talked about side effect is something called ARIA, amyloid-related imaging abnormality. And it comes in two types. ARIA-E, the E stands for edema or swelling, and ARIA-H, the H stands for heme products, but microbleeds is what we're talking about. Mostly asymptomatic and resolve spontaneously. So although it sounds very scary, swelling in the brain, microbleeds, who wants bleeding in the brain? Mostly without any symptoms and resolves without any treatment. In the small percentage of cases where ARIA is symptomatic, the severe reactions or severe symptoms are very, very rare. Not to be ignored, we monitor for them. We adjust doses or hold treatment accordingly, but fortunately, these are very rare. 90% of ARIA will occur within the first 6 months of treatment. So once somebody's past that first 6 months, they're really out of the side effect risk period. And we now have this 4-year data, as I've explained, where we don't see any new signals, just that first 6 months that we already knew about, and then we basically drop to the placebo rate of side effects. We do monitor with MRIs because ARIA can be seen on an MRI, even if there are no symptoms. And here's the kicker. People with 2 copies of ApoE4 have a higher risk of ARIA. That's why Health Canada is being so restrictive. And they're saying that, no, we can't take the risk of ARIA in ApoE4 homozygotes, even though it's mostly asymptomatic, it resolves, is mostly within the first 6 months, all of the things I told you. And my view would be let patients decide if they want to take this risk or not. But right now, Health Canada says no. People who have a pre-treatment MRI scan of the brain that shows what I've put on the slide, CAA, that's a fancy short form for cerebral amyloid angiopathy. And what is that? Evidence of previous bleeding in the brain. So Alzheimer's protein amyloid makes blood vessels leaky. And even without any antibody treatment, people can have microbleeds. And if there are a bunch of these, 5 or more, then that increases the risk of ARIA. So we look for prior evidence of hemorrhage, bleeding, microbleeds on a pre-treatment MRI scan. So we have lecanemab, it's approved, we're waiting for a drug, people will start being dosed at the end of the year. That's so exciting. And what's next for amyloid lowering treatments? Well, Health Canada is poised to approve a second disease slowing treatment, donanemab, and anytime now this could be approved. You know, I think Q1 2026, but who knows, could be earlier. We'll have to see. In addition to this, prevention studies with lecanemab and with donanemab are ongoing. And what do I mean by prevention? People who have no symptoms, they don't have mild cognitive impairment, they don't have mild dementia due to Alzheimer's, but they have amyloid in the brain. They're in the preclinical stages. And the thinking is that treating even earlier, going earlier to these what we call pre-symptomatic stages, we may get even more benefit. And imagine preventing people from ever going on to symptoms. That's what we're trying to do. So then it's not so scary. You've got amyloid, there's a treatment, we get rid of amyloid, and you never go on to develop what we think of now as Alzheimer's disease. Another important advance is that a subcutaneous formulation of lecanemab, so that's with an auto-injector that you inject yourself under the skin like Ozempic, has been approved by the FDA for maintenance dosing. So after a number of months of intravenous lecanemab treatments, one can switch now to subcutaneous dosing so that you can travel, you're not tied to infusion centers, you can self-administer the drug. Even more exciting from my standpoint is that the initiation subcutaneous dosing is under review by the FDA, so that people could start their treatment, never have to go to infusion center or have intravenous treatments. They start with the subcutaneous autoinjector. And I think we'll see that in the US fairly soon. It's under fast track review. And I sure hope that Health Canada will speed up their process so that we can have that in Canada. It will come, and we see evidence that it's rolling out, will be rolling out just south of the border and in other countries for sure. There are other anti-amyloid antibody programs. There are some that cause less ARIA and very rapidly lower amyloid. We're excited about that. There's a drug called trontinemab that we're particularly excited about in that regard, and I don't want to burden you with all kinds of funny names of drugs, but just to know that we're not stopping here. Lecanemab's a big deal. Donanemab's another big deal, but there will be more. And when you get a new class of drugs, then you usually get next in class, better in class, best in class. So we're not done with the antibodies to lower amyloid, but there are other approaches to targeting amyloid as well that include shutting off production. So rather than mopping up proteins that have accumulated and already caused some damage, what if you could stop amyloid from being formed in the brain? And this is going on in trials that are very exciting now, so not yet approved, but here I've put a phase 1 study. It'll be going into phase 2 very soon, of a gene silencing drug. So siRNA means small interfering RNA. So it prevents RNA from producing amyloid. And this drug is a biologic. It's given by an injection. It's called intrathecal injection. So that's around this, into the spinal space. Let's put it that way. Every 6 months. So imagine twice a year you get a treatment, and this gets directly into the brain. It turns off the production of all forms of amyloid. And to date, and I've presented at many conferences, the results as they've come in over time, we see very dramatic knockdown of amyloid production and sustained effect so that you can have this every 6-month treatment. Another completely different way of interfering with amyloid production is with a drug with a very fancy name, valyl trimiprazate. Try saying that 3 times. And this is an oral drug. So we're really, touching intravenous, subcutaneous, the intrathecal admin, and now a pill. And what does valyl trimiprazate do? It stops amyloid monomers, so the early amyloid formation, from aggregating and becoming a more toxic form of amyloid. So amyloid goes through a transition from monomers, single molecules, to aggregated forms. Oligomers are a group of, a small group of amyloid aggregated together. These are thought to be the most toxic form. And then oligomers become fibrils, and fibrils become plaque. And we've talked about clearing plaque, but if you could prevent formation of oligomers, which are the most toxic form of amyloid, then you can protect the brain in a very important way. So we've had phase 3 results read out just in July of this year that show that there is clinical benefit for those at the MCI stage, where there's a huge unmet need, in people who have 2 copies of ApoE4. Okay, so exactly the group that's being excluded, these ApoE4 homozygotes, as we call them, excluded from lecanemab. We're preserving hippocampal volume. What is that? The part of the brain that's so important for memory. We are sparing brain cells. We are saving brain cells there in this group with MCI, with this oral drug. And there will be another phase 3 study to confirm these results. And we look forward to having an oral treatment for MCI and ApoE4 homozygotes. And I should say, even though it's not on the slide, this drug does not cause ARIA. So there isn't the worry for any genotype, but particularly for the ApoE4 homozygotes, who are the most prone to ARIA. This drug doesn't cause it. So let me just show you the 2025 drug development pipeline. I think I showed you the 2022 drug development pipeline, and the number of molecules, all these little colored squares and circles and triangles represent unique molecules. The number keeps growing. And if you look at the big wedges, if you look at the green and the purple wedges of the pie, what you see are all of the drugs that are for slowing down the disease. So disease modification, changing the trajectory of the disease. So at least 2/3 of the drug development pipeline is geared towards that. A smaller proportion is geared towards treating symptoms, that's in the orange, and others in the blue are for treating neuropsychiatric symptoms, so agitation and delusions and things that are so troubling for people with the disease and for their families. So we need to do both, and fortunately we have good representation of drugs across these various broad targets. But if you look at the different colors of all of the unique drugs, what you see is the different mechanisms of action. And just very briefly, everything in red targets amyloid. Everything in blue is targeting tau. Lots of different ways to target amyloid and tau. Everything in yellow is targeting inflammation, which we now know is very important to target in the brain. And there are other colors, other mechanisms. So we're really having a lot of shots on goal here, a lot of opportunities to make a difference in the drug development pipeline. And that's 2025. So that's already knowing that we have lecanemab and donanemab approved. And here, just to summarize a little bit what this pipeline shows, 138 unique drugs being tested in 182 trials. And in phase 3, I think I mentioned this before, 31 unique drugs that we can hope to see readouts on in the near future. So phase 1 to 2 to 3, that takes many years, but those in phase 3, we're eagerly awaiting results. I think I mentioned 3/4 here are disease targeted therapies to slow the disease, 25% to treat symptoms. And importantly, we are covering the full spectrum of the pre-symptomatic stages of disease, where several prevention trials going on, and we need these to be successful. The first will start reading out in 2027, 28. So that's around the corner, that we may have something for people who have amyloid in the brain and don't yet have symptoms. That would be another huge game changer. And then maybe we'll start screening in family practice offices for this early amyloid change, even in people who don't have symptoms. Lots of trials in the mild cognitive impairment stage of the disease and also in the dementia stage. So we haven't abandoned people who are later in their disease. There have been some new readouts finally on lifestyle strategy. And we have known for a while, and I know that I mentioned to you back in 2022, that there are lots of things one can do to grow a bigger and better, more resilient brain. Now there's even more evidence that there are many things that do help protect the brain. The Lancet Commission came out with a report in 2024 saying that up to 45% of all-cause dementia may be preventable through lifestyle modification. So that's all cause. That can be head injury, stroke-related dementia, other kinds of dementia, but Alzheimer's is part of that. Some of the main tenets: mental activity, to pursue activities that are challenging, entail problem solving, or have novelty. So what we're doing tonight together, learning new information, that counts. That's important. It's not all about crosswords and Sudoku, although if you love those activities, those are good ones, but people should pursue things that they like. Physical exercise, the guidance now is moderate intensity exercise, 150 minutes per week. And you can break that down into a daily, 30 minutes or whatever works for you. Dietary pattern, same recommendation as for protecting the heart. Lots of fruit and vegetables, not too much animal fat, not too much red meat. And sleep, quantity and quality are important. So if you're having trouble sleeping, get it checked out. During sleep, We clear amyloid from the brain. Channels magically open up. It's really interesting. We've just learned this in the last few years. They're called glymphatics, and you clear waste products from the brain, including amyloid. Other things that happen during sleep, you consolidate memory. So what you learn, whether it's from today's talk or from speaking with a friend or watching the news, you take that from short-term memory and put it into long-term memory during sleep. So it's more resilient and less disrupted. You can, recall it at later dates. Another thing that happens during sleep, I'm pretty excited about what sleep does. The brain really is very busy during sleep. It's just doing something different than what it does during the day. Another thing it does is it strips away emotion from fact. And so you may have had the experience where you're all churned up about something is really bothering you. You go and sleep, and then the next morning, yeah, you remember how you felt, but you're not quite as stressed out about it. You remember it, but you're able to act on it maybe more logically and in a more productive way because the emotional component is not so imbued in the recall of the memory. Other things, stress management, controlling vascular risk factors. This is really a talk in and of itself, but this 45% risk reduction that the Lancet Commission talks about, there was a study called the Pointer Study presented again in July at a major conference, 2025, reaffirming that dietary pattern, structured exercise, physical exercise, and cognitive engagement can improve cognition in people at risk for Alzheimer's. So people who had a family history of Alzheimer's or maybe ApoE4 carrier status at risk for Alzheimer's engaged in structured lifestyle strategy program improved their cognition. So that's again, affirming of what we suspected. And of course, because we don't yet have a cure, I wouldn't be doing us all a favor not to mention clinical trials. There are many of them. And these offer access to diagnostics, but also to treatments that are not yet available. So I mentioned trontinemab, maybe one of the safest, most effective of the anti-amyloid antibodies to come. Access to that well before market approvals. We have people who have been on lecanemab in our center for up to 6 years because they participated in a trial, whereas the Canadian population in general will just start getting access to lecanemab available commercially. So you can see the advantage of joining a trial. Other advantages, access to an expert team of specialists and close monitoring of one's condition, and the satisfaction that you're doing everything you can for yourself and for other people, future generations. Sorry. So I've always thought and still believe that people who participate in trials are medical heroes and they come from all walks of life. And this is what our pharmacies would look like if we had no clinical trials. There would be no drugs for COVID, no drugs for diabetes or hypertension. It's just so important that we understand when we go to the pharmacy and fill a prescription that thousands of people participated in a research study to bring that medicine to the market. So you can see the evidence of progress. It's palpable, it's real. And people who know Alzheimer's disease have seen it close up. They want to be involved. And they are calling us and saying, is lecanemab right for me? And we're very happy to assess them for that. If lecanemab isn't right for them, there are other options. And we certainly would offer baseline memory testing. We would have people join our prevention and treatment registry. They can undergo a cheek swab to check their risk. They can find out about clinical trials. So the menu has just become much broader now. And we all have a role to play in ending Alzheimer's. And I look forward to my children not having to deal with this disease. I do believe this is a preventable disease. It's just taken us such a long time to get to where we are now. So let's protect the next generations. And I'm very happy to open this up to your questions. Oh, and here I just have one last slide, and this is of Justine, who's on the call with us tonight. If you have any questions, you can connect with her very readily. She's very responsive and knowledgeable. So I'll just leave that up for a moment, and I'll stop sharing, and really interested to hear what your questions might be.
So thank you so much, Dr. Cohen. It's always so inspiring and hopeful when you bring these messages of what's out there in the research world. You know, there's progress, so much progress being made. It's just so wonderful to hear about it.
And after years of people thinking we're never going to get there, trial after trial failing. And why were they failing? Well, we were biologically confirming people had Alzheimer's disease. We were enrolling people in trials who maybe didn't have the disease. And we were enrolling people late, and you need to tackle the disease early. All kinds of reasons that we've learned. We learned the hard way, but we have learned. And I think that's what's so hopeful. So trial designs now are much better, and we are going to have more successes.
Oh, absolutely. When we know better, we can do better.
Yeah, you said it.